Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Effects of Abiraterone Acetate on Androgen Signaling in Castration-Resistant Prostate Cancer in Bone, by Eleni Efstathious et al. My name is Mary Ellen Taplin, and I am an Associate Professor of Medicine at Dana-Farber Cancer Institute, Harvard Medical School, in Boston, Massachusetts, in the United States of America. My oncologic specialty is genitourinary cancers, particularly prostate cancer. The importance of tumor biopsies for analysis of mechanisms of response and resistance in prostate cancer. This podcast will summarize the results of Efstathious et al. And discuss possible mechanisms of resistance to castration-based therapies in prostate cancer. Castration-resistant prostate cancer is a terminal disease that generally evolves after a favorable response to primary androgen deprivation therapy. The work of several laboratories has demonstrated that under the selective pressure of medical castration, resistant prostate cancer cells upregulate the enzymes needed for the intracellular synthesis of androgens. These changes result in active androgen receptor regulated tumor growth despite castrate levels of serum androgens. Thus, castration-resistant prostate cancer cells are neither castration-resistant nor androgen-independent. Coincident with insight into the biologic basis of prostate cancer resistance has been the development of potent therapeutics able to suppress androgen signaling beyond standard deprivation measures. Abiraterone acetate is a CYP17 lyase inhibitor and is able to reduce serum androgens to undetectable levels. The effect of abiraterone on intratumoral androgens has not yet been evaluated. Abiraterone recently demonstrated a survival advantage in castration-resistant prostate cancer patients previously treated with docetaxel, and was FDA approved for general use in these patients. In the study that is the subject of this podcast, Efstathious et al. Treated 57 men with castration-resistant prostate cancer with abiraterone and evaluated androgen signaling and testosterone in blood and bone marrow. The clinical measures of response in these patients were similar to previously reported trials. 50% of patients had a 50% PSA decline, and patients remained on treatment for a median of 7.6 months. There were 7 grade 3 toxicities, which included 3 episodes of hyperglycemia related to prednisone. The unique aspect of this work is the systematic harvest of bone marrow biopsies and aspirates for correlative analysis. However, actual bone marrow tumor harvest, which was defined as having greater than 5% tumor in the sample, was performed in only 25 of the 57 patients. Thus, conclusions based on analysis from actual tumor samples are limited. However, on these 25 samples, there was a correlation between intense nuclear androgen receptor expression and cytoplasmic CYP17 expression with a longer time to treatment discontinuation. These observations suggest that tumors demonstrating active androgen synthesis and engagement of the androgen receptor were likely to respond to inhibition of the androgen receptor pathway. 71% of patients had bone marrow aspirates at 2 time points for analysis of testosterone and dihydrotestosterone by mass spectrometry. The authors are the first to demonstrate that bone marrow aspirate testosterone and dihydrotestosterone were at less than picogram per mil levels during abiraterone therapy. Additionally, in 27 patients on prolonged abiraterone therapy, bone marrow aspirate testosterone levels remained depleted at progression. The authors concluded that progression on abiraterone is possibly testosterone independent. The major limitations of the data presented include small patient numbers, lack of standardization in the field for using bone marrow aspirate hormone measurements as biomarkers, the dilute nature of the aspirates as 5 mL was aspirated, and the limits of mass spectrometry measurements at such low values. Nevertheless, the authors should be commended on their diligent efforts to obtain metastatic tumor and microenvironment samples in the context of clinical investigation. Avenues of escape from abiraterone response will be heterogeneous and are likely to involve continued androgen receptor signaling through either androgen receptor or ligand alterations, or both. At this point in time, tumor changes developing under the selective pressure of abiraterone have not been thoroughly investigated. However, understanding mechanisms of resistance to abiraterone and other prostate cancer therapies is paramount for progress. Current clinical challenges include an assessment of optimal sequence and combinations of available and developing therapeutics. These challenges have been routine for cancers such as breast and colon, which have had multiple approved agents. However, until recently, these therapeutic dilemmas did not exist in prostate cancer. Although difficult, moving the field forward will only occur through trials which include correlative assessment of actual tumor samples, as done by Efstathious et al. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.